Right, so we're here today with Peter LeFeuvre. Hi Peter, thanks for coming to chat to us
Hi.
today. So Peter, I just thought we could start by, if you could just tell us a little bit about where you work and how you work with amputees, just to let our listeners or watchers know, and then we'll just have a little discussion about pain management.
Okay, yes. Well, currently I'm working in Germany with the British military there, but previously to that I was at Headley Court, where I worked for a number of years with the battle casualties and so the amputees, principally the amputees coming through Headley Court.
Excellent, so you've got quite a few years of experience working with amputees.
Yeah, that's right, yeah.
Okay, good. And so this week we are on our amputee course. We are talking about complications post-amputation and pain management. And you were very kind to write some of our pain management content in Physiopedia. So I just sort of wanted to just chat to you really quickly about a couple of things about pain, if that's okay.
Yeah,
Yeah.
go for it.
So I mean, I have no experience of amputees, so I'm interested in this. What kind of percentage of amputees have problems with pain after their amputation?
Well, I think that when you start talking about pain, you have to clarify that there's different types of pain involved. So everybody post-amputation will have problems with nociceptive pain. So that's the consequences of the wounds, the amputation, and so on. A certain percentage could well then have what's known as phantom limb pain, and the data out there is a little bit uncertain. Some people would say it's 40%, some people go up to 80%. I think my experience working in both an acute setting and a rehab setting is that virtually every amputee that we saw certainly had some form of phantom limb sensation, and probably a significant majority had phantom limb pain as well at some point in their recovery.
So is phantom limb pain the most prevalent pain-related problem that you see?
No, I think the phantom limb pain, or certainly chronic phantom limb pain, we saw very low levels of that chronically. I think what was more common was seeing a mixture, certainly in the acute stages, of having residual limb pain, which is the term we use to refer to post-amputation pain. So we saw a large number of guys with that, and then coexisting beside it was then a phantom limb pain, which may have been initiated by all the other sort of the residual limb pain that was ongoing as well. So a mixed presentation, but certainly in the acute phases, that was very common.
Yeah, so it sounds like could I summarize it by saying that you could say that every amputee will have acute pain of some description, whether it be residual limb pain, post surgical pain, or phantom limb pain or sensations, and then a lot of those will recover, but some of them will continue with some phantom limb pain or sensations.
Yeah, yes,
Yeah.
and certainly the prevalence, from my experience anyway, of between upper limb and lower limb, I would say that we saw an awful lot of guys with upper limb amputation that had problems with ongoing phantom limb pain, but the lower limb guys it was much less prevalent, and I think and that it seemed to tie in. And I think the research supports this with how quickly you can fit them with a prosthetic. So the quicker you can give them a device which I suppose that they're seeing, that they're using, that becomes part of them, then it seems to work and to help treat the presentation of the neuropathic presentation, the phantom limb pain.
That's really interesting. So that's quite an important thing to remember, that the quicker you can get them their prosthetic, then the less likely they are to have issues with pain. So that's good to know. And then going on to the pain management side for the people that do have pain, what are the most useful techniques or management techniques that a physiotherapist or other healthcare professional working with in the rehabilitation of amputee patients, what are the most useful things that they could know or use or do?
That's a massive question.
I know, sorry.
I think trying to keep it concise, I think in the early stages, being proactive or even aggressive with your analgesic response, giving them, so loading them sufficiently so that they have very little, if any, pain at all. Being proactive with the use of neuropathic medication as well, amitriptyline, pregabalin. Certainly, I feel in our experience was effective. You've got the complication as well in the acute stages of wound management and therefore residual limb pain and the need to prosthetically fit. And we, within the military, we would prosthetically fit very, very quickly. There was no, there was no PAM aiding or very little PAM aiding and use of intermediate prosthetics. It was we were lucky enough to be able to almost go straight to some form of fitting, and I'm sure that was effective. But you have to balance that with their wound management. But the thing that we really learned with the upper limb amputees was to get them prosthetically fitted within 6 weeks. So that was our guideline. That's what we were trying to work to get them something onto their upper limb because that then allowed them to remember. It stopped them forgetting how to use the amputated side, but it also seemed to help with, as I've talked about before, with this phantom limb presentation. So that's in the acute phase. In the subacute and rehab phase, again, it goes down to prosthetic fitting, and it goes down to, but it's also about making sure that your teaching of using the prosthetic is allowing them to own it, if you like. So it's so that do they walk well with it? Do they have good muscle balance, good core stability? Are they strong enough? There's that aspect as well, and as well as the ongoing medication. And I'm trying to think of other things.
That's fine. I mean, it sounds like the most appropriate thing is to just make sure that you're sort of actively and appropriately managing your patient with rehabilitation. So making sure that that you're doing the rehab exercises, that they're strong, that the prosthetics fitted quickly and correctly, and all those sort of things. It's not specifically pain management techniques. It's making sure that the overall management of your patient is correct, isn't it?
The one aspect I've forgotten about, actually, which is really important, is education. And if you go through any of Lorimer Moseley's work and the graded motor imagery, you educate the patient and you help them to understand what's going on and what to expect. That really helps significantly. And I think as well, having an understanding, not just physically about what's going on, but I think having some appreciation of the psychological impact of and gaining support for the patient where that's needed is also important. So it's referring back to the biopsychosocial model that we're seeing increasingly talked about, that we're not just dealing with physical beings. You've got a psychological, spiritual, social, emotional aspect to bring into your assessment, especially when you're dealing with pain.
Yeah, really important, really, really nice addition to to the clinical rehab that we all think about. Really important to remember the patient education side and all those biopsychosocial aspects as well. Yeah. That's really good. That's really, really helpful. Is there anything new, any particular other aspects of pain management that you'd like to just mention before we close off this chat?
I think the first thing is, I've never seen, whenever I've been successful with one patient, it's never worked with the next one. Every single patient is really individual. That's the first thing I've learned. The second thing is to think broadly about using your musculoskeletal skills. trigger pointing, muscle balance, core stability. A good amputee physio and a good pain management physio will have a strong appreciation of the role of the musculoskeletal as well as the other aspects. And I think that's probably where it's. The other angle I wanted to just bring in very quickly was don't just think down one route. So we found with the upper limb guys that we were really struggling with that, combining things like graded motor imagery with acupuncture or TENS machine at the same time. Think laterally and experiment with things. I've got no research to say that that's a good way to go, only that from our experience. Sometimes combining the therapies was really helpful as well.
That sounds interesting. You don't hear that talked about much, so that's useful to know. I've just got one more question thinking about what you've said. So you've talked about how it's important for timely and quick prosthetic fitting. What about for patients that come 6 months after they've had an amputation, which will be seen sort of more in low-resourced and low-income countries?
That's it's a good point. I think. I think in low resource, well, I think in any scenario, I think that it goes back as well to what level of amputation is being prescribed. And I mean, it's a brief aside that we found certainly using through knee amputations, which is not very common, preferable to above knee amputations for a number of reasons, which I won't go into here. But in developing countries, that's particularly useful because you can weight bear onto them, so you can still. So on a through knee amputation, you can still walk on the end, the stump end, because you've got a weight bearing surface, even if there isn't a prosthetic to fit onto. Or you can use stubbies. So stubbies is another really good is a prosthetic device that keeps them low to the ground, and they can. So it's about getting them walking and getting them moving as quickly as possible. So you're activating the glutes and all the other stabilizing muscles around the pelvis. When you got somebody coming 6 months down the line, you just got to play catch up. You really got to make sure that you get the range of motion into particularly the hip joint. You've got to get the glutes strong. Got to get the abdominals, the adductors working well, and I think maybe if there is an ingrained phantom limb problem, then or problem with chronic pain, then you've got to also think down I think graded motor imagery has a lot to offer us there, looking at the laterality and the mental imagery and so on. So in that short answer, there's a lot to sort of like delve into, but hopefully that gives a few pointers.
Yeah, no, I know it would be easy to talk to you about this for hours and hours, but I think that's really, really useful to hear you talk about how you might deal with those patients that come to us 6 months down the line or later on after their amputation. So thank you. Anything else you'd like to add, or otherwise we'll close up this chat?
No, I mean, hopefully it gives you a few pointers. I think really if you look at the papers, the articles that are out there, Herta Floor is a great, has done loads of research. Really
How do you spell that?
Herta, Herta, Floor is Flor, I think it is.
Okay.
And she's worked with Laura Mosley and that side of life, and I think they're really good articles to delve into to get an appreciation of the neuropathic element to what you're dealing with phantom limb pain. So read around it and look for those names.
Excellent. I think we'll add links to those names and those authors so that people can look them up. So thanks very much, Peter, for talking to us today. That's been really, really useful.
Okay, thank you very much. I find it a really interesting subject to talk about because I feel I'm dealing more with chronic musculoskeletal injuries now rather than phantom limb pain. But I take the same sort of approach, and I think it's the thing I didn't probably bring out in that is I always think with pain management it's about working out where the driver is, and I think I tried to emphasize that in the article. And I always I always, I think I like talking around it either with a patient or with a colleague, to try and work out what are the social issues, what are the emotional, the psychological, the
Okay.
physical. But I think with amputees side of life, what's really important to bring out is that our experience in complex trauma at Headley was that the strongest physios were ones that were really good musculoskeletal practitioners that had worked in the sports environment, that had good hands-on mobilization, manipulation skills, and it was just that restoring movement, providing strength, and use their prosthetic well. And once, I met. I mean, I could talk about this for ages, but I met a guy on an exercise where he was actually there as a casualty, pretending to be a casualty. He's a 5-year-old amputee, so he's had amputation for 5 years, and he was saying, oh, I've got really bad phantom pain at the moment. So I had to. My prosthetic fell apart last week, and I haven't had it for a week, and my phantom pain's come back, and I've not had anything for 5 years. And I thought, and it sort of hit home just how important having how important our visual senses, which seems to override our somatosensory, our motor elements, and it so that his neuropathic response returned because he didn't have that visual leg in front of him. And we had a patient when I was working in Birmingham. He was I think he was a few weeks down the line from amputation, and he came back to us, and he decided to make himself a papier-mâché leg. He came up with this as an idea that it was in our early days, and he just was getting lots of pain, and he made this leg for himself, and it took his pain away. And that started me thinking down this line, and that's how I got into reading Herta work and Lorimer Moseley, and people who I think have personally been very influential in how I've worked since. So the more that people can read about these guys and hear these examples, maybe it'll expand their creativity.